Mhm.
Welcome, everybody, to a Friday edition of our Thursday Night Live webinars. My name is Ann Blau, and I will be hosting the esteemed Dr. Bill Hang today, who will be presenting on the topic of rediscovering the health reasons to treat in the primary and mixed dentition. And if you are an Airway Circle member, you are able to watch this in advance. So Dr. William Hang, or Dr. Bill Hang, as I think he is known widely, is a pioneering orthodontist dedicated to airway-focused treatments that enhance overall health. After earning his dental degree from the University of Illinois and completing orthodontic training at the University of Minnesota, he initially practiced traditional methods, but later became a leader in non-retractive orthodontics to improve airway health. With a career spanning 50 years, he received a Lifetime Achievement Award from the American Academy of Physiological Medicine and Dentistry. As the founder of Ortho2 Health, he continues to mentor professionals in his early childhood health-centered orthodontics program and an airway-friendly orthodontics for patients of all ages. Dr. Hay, it's a pleasure to have you. And I turn
Happy
the
to be
floor.
here.
Thank you.
Hello, Renata.
Sorry, I know I'm interrupting. I just came to say hi. When I
Oh, good to see you. Okay.
Cannot wait to hear this.
Okay.
Thank you for being here. Appreciate you. Thank you, Anne.
Okay. It's time for me to share my screen now and start.
Welcome to share your screen. Yes.
Okay. And let's do that. And so now here I am. So very good. Thank you very much for giving the opportunity to do this. It's a great passion that I have. Yes, I'm retired, but the important part of that is that I'm semi-retired. I couldn't stand to be retired and put myself out to pasture. I care too much about what I do, which is why I like to share things that are very important to me. The title here, Rediscovering, may be astonishing to some of you because, you know, orthodontists more than 100 years ago were treating in the primary and mixed dentition. And that's not something that's routinely done in orthodontics today. I'd like to share with you why they were doing that and why I think we need to get back to that. Let's get started with this. Long before I was on planet Earth, even though I'm retired, I'm not that old, but I know about the Titanic sinking and that kind of thing. And so back in those days, orthodontists were really treating the primary dentition. So here we have some articles out of that era. Here is one 1912 talking about treating by age 6, widening the arches, both arches, and creating spaces between the teeth. Interestingly, most orthodontists today still wouldn't even believe in widening the lower arch. They think that you would be pushing the teeth off the bone support. Of course, that's what I was taught. That's not what I know. Back in those same times, you talked about mouth breathing was necessary. Getting rid of mouth breathing would be a healthy growth of the jaws if indeed this was eliminated prior to age 6. That means treating in the primary dentition. Here's a quote from this article that uses the word healthy, which is a word that I have rarely, if ever, seen in an orthodontic journal. That word is not used, unfortunately. It's all about straight teeth. Here's another one back from 1931. We talk about treatments beginning as young as age 3, but by that time it was not being done really, treating at that age. Back in 1909, this article is really interesting. It says, even the brain development is retarded. And oh my gosh, in my orthodontic training, we never talked about retarded brain development, but it was something that had been talked about decades before I came on the scene. So there really is nothing new. I love this book. This is a book from New York. It's a public health book. And in it, they talk about having adenoid parties. Well, I went to plenty of birthday parties in my day when I was a kid, but I'm glad I never had to go to an adenoid party, because an adenoid party was where kids went and they all had their adenoids taken out at one time, which is, I'm glad we've progressed from that. But it's honestly, this kind of thing goes back even into the 1800s, adenoid parties. But the knowledge that we have here goes way back, even to the time of Charles Dickens. Talk about backwardness and delinquency, also crime, criminal behavior and such, associated with these, quote, backward people who were chronic mouth breathers. We didn't have political correctness back in those days, so people kind of said what they thought and let the chips fall where they may. So back in 1922, this is a really important article here, and written by a physician, and he talks about remove the causes of mouth breathing. That was never something that was even discussed in my ortho program. We were just straightening teeth. This one really gets to me. I like this a lot because it's an article written or read in 1931. The child should be asked to run with his mouth closed a short distance daily, causing a forced rapid breathing through the nose. The distance should be gradually increased until the child can breathe as freely through the nose as is necessary. This will enlarge the breathing spaces and correct the habit. I would have read this and thought this is craziness. Having said that, about 13 or 14 years ago, I heard Patrick McCune from Galway, Ireland speak. I view him as the guru on nasal breathing, and I began to run with my lips together after having been running since 1970. But I never thought it possible. But within a few weeks, I was able to do that. And I've run many marathons, and now run my first 19 marathons with my mouth hanging open. Here's a picture of me on my most recent one, which was the Boston Marathon 2 years ago. There I have a picture of me in the upper left with my mouth taped. And I did this as a publicity stunt. I really don't need the tape. My lips together, and I've run, let's see, 15 marathons with my lips together. But I used the tape just as a publicity stunt to make a point. That picture, by the way, appeared in the Times of London, the Sunday Times of London. You see other people here who are catching on with this. Here's a tennis player and another person who ran a marathon the same year in France. Here's someone who did all of us. He's also a dentist, so we know he's crazy. Here, Frank Seaman, I've never met him, would love to meet him. He runs the Pikes Peak Marathon with his mouth taped. I wouldn't want to run the Pikes Peak Marathon at all because I'm not very good at altitude. But here he is, great shape, running the Pikes Peak Marathon with his lips taped. Here we have another runner for the United States, and notice how she is flying along here and ahead in the upper right-hand corner, ahead of the other two girls there, and she has her lips together while the others have their lips apart. And I would never want to argue with anybody on the New Zealand rugby team. They run on the hills of New Zealand together with their mouths taped. So we're really getting this, is becoming kind of a big deal now, where people are recognizing this, courtesy of James Nestor's Breath book and Patrick McCune's book, The Breathing Cure and The Oxygen Advantage. So what happens if you hang your mouth open? Well, nothing good. Here's a boy that we treated years ago, and we straightened his teeth, but despite our admonitions that he should learn to keep his lips together, he never did. So you see the black line here, see how far back his face is. Over time, his face falls back more and more and more and more because he has what we call poor rest all posture. So you say, well, what's the big deal about that? Well, one day he comes in when he's almost 15 and he says to me, I can't breathe. And he says, I hate my nose and want a nose job. Well, I don't even know why he said either of these things to me. I'm not a plastic surgeon, not going to do a nose job. He got a nose job done. In reality, the reason his nose looked like it had a bump in it is because the entire cartilaginous tip and the rest of his face is recessed. The nasal bone was perfectly positioned, but the plastic surgeon takes it down to make it straight, ignoring the fact that he had sleep apnea at age 15. And he has diagnosed that as a horrible airway. You can see the size of it, and that's high risk for sleep apnea. And he did get a sleep test done, and he has apnea. So there's my hero, Patrick McCune, is my friend. I've been to his home in Galway. He's my patient. And I thank him so much for getting me to be a nasal breather. And I tape my mouth every night ever since I met him way back in the day. as he would say, and those of us in this business say, if we just get the kids to have their lips together, as soon as we can do that, everything's going to be okay. Many patients in my practice would come for a second opinion because someone said they had to have 4 teeth taken out. And I used to take out teeth by the truckload, but more than 40 years ago, I stopped taking out teeth entirely, which if I say that in an orthodontic meeting, the room will go silent because somehow now I'm a leper and an untouchable because I don't take out teeth. But that's not the point. I don't want to be retracting ever. I don't want to pull anything back and reduce someone's tongue space. So we say to this child, we're going to straighten your teeth, and we do that. By the way, you need to learn to keep your lips together, which he never did. Send him for myofunctional therapy, which he needed badly, but he never did. So his face fell back just like so many others, and this is what happened to him. His mother takes a picture of him laying on the couch, and he's snoring. And that's what his airway looks like. He has sleep apnea in his mid-teens. So what do you say? That's what he looks like. That soft, behind the soft palate's the smallest area, and that's going to easily seal off, cause him to stop breathing, which puts him at great risk for heart attack, stroke, diabetes, cancer, the whole thing down the road. You say, well, why don't you just put him on a CPAP machine? Okay, that fancy, sexy mask that you put on. But the fact of the matter is, the New England Journal of Medicine talks about the fact that it does not provide a statistical benefit of reducing the chance of heart attack or stroke, which is why people use it. They think they're going to live forever by using it. They're going to feel better, but don't delude yourself thinking you're going to live forever. Let's look at another aspect of this, an article from 2012, which is really well known in the industry here. Karen Bonnick talks about the requirement for special needs education because of chronic mouth breathing and sleep apnea. How many of you want to have your kids have to have special needs? My good friend Phil Cooper, we're on the board of the AAPMD together, practiced in Savannah, Georgia, and wrote this book years ago. It's not about the color of the skin, and he and I've had that conversation. Whatever the color of your skin is, if you've had sleep apnea and you may have brain damage, your child may have brain damage, they may never, ever read well. And that's the sad part. We're accepting that as something that's happening to kids. More research from the literature. I love to study this kind of thing from David and Lila Gozell, two of the best known names in the sleep arena, talking about brain damage with just minimal oxygen desaturation. So this is a big deal. It's not about the teeth. Here's my hero, Ron Harper from UCLA. He has MRIs of brains of young kids who are desaturated just for one night of reduced oxygen saturation. And here he talks about affecting motor coordination. And here we have irreversible brain injuries, which increase the chance of hypertension. Point is, it's a big deal. And here's another one, again, from Gozell, the Gozels. And so, again, documenting brain damage, not something that we discussed in my orthodontic training back in Minnesota, back in the 70s. It's a different time. But I think we ought to be discussing it and should be at the front page news for everybody in this world right now. So it's not about the teeth. So if we're going to do this, what tools do we have in our bag of tricks here to help in this war against sleep disordered breathing? Lateral expansion, and everybody knows that. That's the knee-jerk reaction. More important than that, however, is trying to develop the jaws forward. Much more important if you're going to try to get rid of a sleep apnea, because our faces fall back, and we'll show that in a moment. Again, we'll talk about that a bit more. And more than that, people who are on the front lines of this are the myofunctional therapists. They're the most important people, far more important than orthodontists, and they can be treating a lot earlier. And really, right after birth, they need to get involved so frequently with tongue tie releases and these kinds of things. So we'll talk a little bit about this. Here's a classic thing we see: a father who's a baby boomer like I am. He's had 4 teeth taken out, and he has both jaws recessed from where they ought to be relative to what we call the Bolton norm, that black line. That is his airway. And David Hatcher, who was with beam readers and an oral maxillofacial radiologist, has an article out there with this type, with this small airway here, this person is at great risk for sleep apnea. And indeed, he has sleep apnea. He has medical issues. This then is his daughter with her mouth hanging wide open as a chronic mouth breather. And her face by this time, at age 7 or so, has already fallen back dramatically. And left alone, if she continues to be a mouth breather, it will fall back even more. So here she is, and you look at her teeth, and you say, well, golly gee, what's the big deal here? Yeah, they're kind of crowded. The lower incisors are coming in crowded at age 8. You could leave it alone. You could treat it now. You could treat it later. And I even went to a meeting more recently, and there are orthodontists who would go in here and start removing primary teeth, then primary cuspid teeth because of the crowding, then remove primary first molars, and then remove bicuspid teeth. I quit doing that more than 40 years ago. But what I'm going to show you we're going to do here is we're going to move our upper front teeth forward, which is sacrilege. This is not the standard of care. But look what we did. We moved them up and out. Now she looks kind of weird here, doesn't she? But then we're able to move her lower jaw forward using an appliance which eliminates the headgear effect. And this is what she looks like. Not easy, but it's doable. Now, look at how her face came forward, and that's nice. She looks a whole lot better. She has her lips together. And more than that, this is what her airway went from looking like that on the left with a horrible airway at 13.1 millimeters squared. And now you can see her profile forward like crazy, and it's 186.1 millimeters squared, which is a whole lot better. And her mother, when she saw this, by the way, said, I think I'm going to cry, having seen the massive improvement, not only in girl's profile, but in her airway, which is even more important than looking good. And that's what she looks like. She's an equestrian, goes all over. Let's look at another girl. This is a daughter of a hygienist I treated many years ago, and this is a very classic kind of a case. Class 2 like this, I was taught to use a headgear and shove the upper teeth further back, even though they don't stick out. We've known that since 1981. They're still teaching to use headgear. What we need to do is move the upper front teeth 8 to 10 millimeters forward. Look at her face being back this far. She's a very diligent girl, and she did this. We moved both jaws forward. Now you can see her bite. No longer does she have a gummy smile and the deep bite. Both of her jaws are forward because she's a very disciplined child. A little bit later, you can see she's got some extra spacing there, but it's closing on its own. Notice how the alignment of the teeth without any retainers is staying the way it is. And over time, those spaces close, and she never needed braces. But more than that, look at the facial balance that she got. Now imagine with the upper jaw having moved forward, the soft palate's going to move forward. With the lower jaw coming forward, the tongue is going to move forward. So the big benefit here is an improvement in the airway. So let's switch gears a little bit and get down to some adults. Here's a guy who's in his mid-40s, and he has apnea. That's a pretty poor airway he has. He has sleep apnea. Now, here he has no apnea. He's gone through double jaw surgery to surgically advance both jaws. He no longer has apnea. You can see, relative to the Bolton norm, how far forward the surgeon was able to bring both jaws. Now, that's a very invasive procedure, but it can save somebody's life. Wouldn't it make sense to treat his son in a way that would develop the jaws forward, if that were possible? And indeed, all we need in this boy's case is for the upper lateral incisor teeth, the permanent ones, to be in, and then we could start treatment. So here we are a year later, and you can see the teeth are crowded. In my training, I was taught to take out primary cuspids and then take out bicuspids in case like this, which is the last thing I want to do. What do we do? With an airway like this, I'm guessing he has a very high chance of having sleep apnea, just like his dad. So anything I can do to develop both jaws forward would, in my opinion, be a big positive. Now, please realize I never guarantee a result to anybody. We're dealing with human beings here. All I'm saying is, if you're able to choose your airway, always choose the biggest one. And if I'm going to do something for my kids or my grandkids, I want to do something that's going to do it to optimize their airway, even if it involves doing something which is unfortunately not the standard of care. So here you can see from age 8.5 to 9.5, in just a short year, because his restaural posture was not great, while we had to wait for his upper lateral incisors to come in to begin the treatment, his face fell back dramatically. Not okay. So here we are after we've moved both jaws forward, and he is happy as a clam. He's got some crowding in the lower. Do you think he cares? No, he's fine. I was taught to take out 4 teeth in a case like that. I don't want to treat him. If I were to treat him, I could line the teeth up without removing any, but he's happy. He's happy with what he has. And notice how far forward his jaws have gone. I happen to believe this places him in a lot better position to not have sleep apnea like his father. Here we go. Look at his profile now, relative to the norm, way forward, and his dad, where his dad was after his surgery. I'm really happy that we did this for this boy. Let's look at another father. He's in mid-30s, and he's got a class 2 occlusion, and by the time before he's 40, he has stents put in the arteries of his heart because he's having cardiac problems. I know he has sleep apnea. 35 and a half, almost 36-year-old man with sleep apnea. Here is his son, who is only 5 and a half. And I was treating this boy's older sister with this treatment to develop the jaws for it. And I said to the mother, that's what this boy needs. And she says, there's no way in the world he will do it. And your mother says he will not do it. You believe her. There's no reason to think she's wrong. She knows her son better than I do. So we had to then wait for the upper 4 incisors to come in. And he was almost 11 years of age when finally the 4 upper incisors are in. Very, very late, like 2.5 to 3 years later than we would expect. But that's what his dental development pattern was. So now we have the 4 upper incisors in, and we can now move them forward. But look what happened from 5.5 to 8.5 until we're ready to start. Look how far back his face has fallen relative to the Bolton norm. His face is literally melting away because of his poor restaural posture. So we're not starting in the left with him. We're starting him on the right picture at age almost 11. And with the treatment, he was diligent. In a little over a year, we did get him forward some. He didn't get his restaural posture completely corrected, however. And so from the time he was 12 to the time he's 18 and a half, he fell back rather dramatically. That's kind of sad, because now when you compare him to his dad, who has apnea, he doesn't look so good. So my point here is, what would have happened if we really had been able, had he been up to the task of doing the treatment, wearing the appliances when he was age 5, I think we would have had a much better result. The point then is, what is the point? Well, the point is, we need to not be doing orthodontics, which is lining teeth when they're all in the mouth at age 11, 12, or 13. We need something new than orthodontics. That was the past. That's where my wife and I came up with the term ortho to health, with the middle part being like oxygen, O2, meaning we need to deal with the airway. So we're going to treat the airway in the primary dentition. What a concept. And there's no better person to have as a mother in treating this than some woman who has already had permanent teeth taken out herself. On the left, she's had her teeth taken out and she's not happy. She has a headache pattern. She doesn't sleep well, and I believe she had sleep apnea. We reopened her spaces for her, and she's happy. She trusts me. By the way, she had to drive 3 hours from near San Diego to north of Los Angeles, where I practice, over the 405 freeway, which is well known as being a horribly congested freeway. Just 3 hours one way to see me with her kids, going past literally hundreds of orthodontists along the way. This is her daughter, who's 5 years of age almost. Look at her smile, and all you see is gum tissue. Why is that? Because her upper incisors are down and tipped back and literally trapping the mandible, keeping it from growing forward. That is not going to go away on its own. As a matter of fact, that girl, I would give her a near 100% chance of having temporomandibular joint problems. But more than that, if her face doesn't grow forward, her tongue isn't growing forward, her soft palate isn't growing forward, her airway is going to remain small. Now, her upper anterior teeth are literally 13 millimeters too far back. So her face is already falling back from the Bolton norm. You can see that. She's not even 5. Think about that if that's your daughter. This doesn't self-correct. Now we have fully intact roots in the primary teeth here, so we're good to go. We can move them forward, and as we move them forward, then the permanent teeth that are sitting up there developing are going to follow them forward as well. There'd be no point in treating her in the primary dentition if the permanent teeth were not going to follow those teeth forward. So we're not straightening the primary teeth. We are using the primary teeth as a handle to the face to develop the face forward. So here we are, we take her and we move these upper anterior teeth out into a monstrous overjet, Now we're ready to bring the mandible forward. And we do that with an appliance that negates the headgear effect. Here she is at age 7. Her face is forward. Her gummy smile is gone. Here she is 3 years later. And if I were to treat her again, this is one of the first patients I treated in the primary dentition many years ago, I would have created even more space in the lower, so there would be really no need for any more treatment at all. My goal when I retired was to have patients have their orthodontic treatment completed by age 6. So there was never a need for braces. So the gummy smile on the left is now that smile there. And her face has come forward rather nicely with this treatment. Let's look at her sister, who's even worse off, because her sister has, the mom has already witnessed this child stopping breathing at age 3. Again, think about it. She could be getting brain damage from that every night. Tongue tie she has, terribly important for myofunctional therapists. You all know more about that than I do. And her upper anteriors, like her sister, are massively recessed. And her face is already further back than her older sister, already at a younger age. And her face height is getting longer, which you can see. Not okay. Nobody wants to have a long face like I have. So we do our thing. We develop her maxilla forward, and we create more space laterally as well. You can see all the spacing in her primary teeth. We put some little plastic things on there to help a wire on her upper and centrals. You see that we push all those teeth forward with an appliance we've developed. Then we develop the mandible forward. Now, of course, you can't really tell too well because along the way, here she is at age 5, and she's already lost her some primary teeth, and she's starting an exchange of teeth way earlier than normal. But you can see that her face is coming forward. Now, I don't have x-rays on some of these patients because I honestly, more than 20 years ago, 25 years ago, I did a study on a lot of my patients I'd taken x-rays on, and we saw a nice improvement in their airway. But I stopped taking x-rays because I knew what I was finding. There was no need to document further, and I didn't want to radiate kids just for my own purposes. So there's a boy coming from Chicago referred by the head of the pediatric sleep clinic at Lurie Children's Hospital in Chicago, referred to Los Angeles. This young boy who has Pierre-Robin sequence and sleep apnea and failure to thrive. Failure to thrive means he's not growing. Why is he not growing? Not getting human growth hormone. Why is he not getting human growth hormone? Well, he's got sleep apnea, and I'm an orthodontist. I can't tell you all about growth, but I understand that more human growth hormone is secreted during certain types of sleep, which he is not getting. So we do our thing, and we develop the jaws forward and laterally, and his airway opens up like that. And in cross section, you see this improvement. And my good friend Steve Sheldon, who's now retired, has this book here, and this is written up in the book. This boy's sleep apnea is gone. I remember very well the day that Steve called me from Chicago and said that this boy's sleep apnea was gone. So I followed up. The family no longer lives in the Chicago area, but I followed up with an email to the mom, and this is what she said to me. This was let's see, 4 years ago. And here he is with his sisters, and he's an aggressive tennis player doing well in school. So by now he's in college. Now, I happen to believe that this dramatically helped him. And think about it, if he was getting brain damage, as Ron Harper said, he might have had muscle coordination with Purkinje cells being killed, and his motor coordination might have been affected. Maybe he wouldn't have done as well academically as well. So is there science behind this? People will say to me all the time, oh, we don't have any science to prove this. Oh, really? Well, what about this? We did a study of my patients, and you can see, by the way, this picture, the picture of this patient on the left and the right, the x-ray. She's class 2, and she came to me for a second opinion after orthodontist had said she needs to wear a headgear and have 4 bicuspids taken out. And we said, no, we're not going to do that. We're going to move your upper teeth forward and your lower jaw forward, and you're going to have nice teeth without any headgear. We're going to get your face forward. And you can see the dramatic improvement in her airway from the left to the right. I've superimposed this, the number there is 31%, is a study we did. I didn't do the study. Someone else took my patients that I treated with this technique and found on average, the airway in that area was improved by 31%. The angle of the mandible behind the tongue was 23%, and clear down in the laryngopharyngeal area, 9%. Now, this included patients who wore the appliances really well and those who did not. If we only included the real cooperators, the numbers would have probably been better. Again, I never promise anybody resolution of one symptom. I've never promised anyone their airway would get better, but I know full well that I'm doing the right thing when I do this. And John Rimmer is a Harvard-trained physician I heard speak at a sleep meeting many years ago. He owns patents on a lot of the things, sleep apnea, CPAP machines and stuff. This is one of the most important things he said. And I was ready to jump up on the table and scream and holler in support, because he said that the sleep apnea would not exist if the jaws were properly forward in the face. And I want to emphasize the word forward. What you're seeing in the sleep arena is everyone's expanding laterally. They're doing so aggressively with temporary anchorage devices, sometimes with surgical assist. Most of the time it's unnecessary. You don't need that stuff. I've expanded child 17 millimeters with none of that kind of craziness. So the point is, you need to be developing the face forward. If you don't believe me, let's talk about that right now. So here's a kid who he was treated with an alpha appliance, which is a great appliance to do expansion. Massive, massive width achieved with this appliance. It's phenomenal for that. Look at it. But he still has sleep apnea. His face is not forward. And you can see how far it is back relative to both norm. It's not going to get better. How about this girl? She's in her late teens, and she's got a appliance in with a 43 millimeter intermolar width, which is wider than mine, wider than most people that come into anybody's office today. That's a really wide arch, but she doesn't awake well rested and snores occasionally. And that's where her face is. She's way back. She's snoring now. Snoring alone is correlated with plaque formation of the carotid arteries. That came from, without a sleep apnea diagnosis, that came from Henry Ford Hospital in Detroit, Michigan, probably a decade ago. You can go look it up on the internet. That's her airway. She's better off than her brother, who is a fraternal twin with an even wider intermolar width. Very few people have this much of an intermolar width. This is remarkable. The alpha's done a phenomenal job at getting nice width here. But what about his mandible? What about his lower face? He snores, and sleep apnea may or may not be an issue. He won't go get a sleep test done, but I can tell you, if that's my son right there, and that's his airway, I'm not even a little bit happy. I happen to think in the long run, if he doesn't have sleep apnea now, he will in the long run. The only way out of that for a guy this age is to do double jaw surgery to advance both jaws. That's how far back his face is. You say, well, he'd look funny if his jaws were that far forward. No, he wouldn't. He'd look great. Look at his forehead. It's tipped back. Why do you think his forehead is tipped back? Did you know that forehead should be vertical, straight up and down? Hardly anybody has that, but that's what they should be. He tilts his head back to keep his chin forward, to keep his airway open, because he'd like to stay alive. So here's another one. 38 millimeter intermolar width. I don't know who treated him, doesn't matter. I don't know how he's treated, but that's a wider intermolar width than most people have. He's restless, awakens often, can't get back to sleep, and he has a sleep test done, and he desaturates to 80%, but nobody recommended any treatment. Do you think maybe he's desaturating and having brain damage? He's on Prozac and Vyvanase. He has ADHD. Steve Sheldon, my friend from Chicago, who's research in the sleep arena, now retired, says he doesn't believe that there is such a thing as ADHD. He says he believes it is always, which is an interesting word for a researcher, isn't it? Always a sleep and breathing problem. And we have 15% of our kids diagnosed with sleep apnea today. I've seen that subject. It could be more, could be less, but I also have literature I could show you that says that ADHD, people with ADHD do not live as long as those who do not have it. And that we could get into the behavioral aspects of what happens to kids with ADHD and why they don't succeed in life as much and how they often get on the wrong side of the law. So he's way back like that. Where's he going to be in 20 years? Not okay. So here's a patient diagnosed by a summer camp counselor with sleep apnea at age 11. You say, well, why didn't his pediatrician diagnose this? Well, you can speculate on that. Most pediatricians are not in that arena. They don't recognize this. Too late for me to bring his jaws forward. So the only thing I can do here is to expand laterally. I don't want to get involved with the treatment to develop the jaws forward in a child this age for technical reasons and behavioral reasons. And his jaws are back that far. Realize he's an Asian and his nose is shorter, which is why his face doesn't come forward, his nose doesn't come forward as much, because that's a Caucasian norm. We don't have an Asian norm. That is his pitiful airway, which is consistent, in my humble opinion. That's his airway. I have to believe that he has brain damage already, and he is a very sad boy. That's his airway he's trying to breathe through. We expand like crazy. Again, please notice that we haven't pushed the teeth off the bone support, despite the fact that we've expanded him 10 millimeters, and we know there's no midline suture in the mandible, but you don't see any gum recession. I wouldn't be doing this if that were happening. I have two boys I did this for, by the way. One is 49 and one is 47. And we did it for my soon-to-be 16-year-old grandson, who's 3 inches taller than I am, expanded his jaws, and he doesn't need any braces. Nice big teeth and enough room for them because we created that space. So with our treatment here for this boy, we went from a whopping 12.8 millimeters squared to 43.4, which is no big deal because he's still got a horrible airway. So now we know he still snores. Now we advance his teeth. This is where it comes in, to advance the upper and lower teeth. Now we've advanced them. I was taught, of course, never to push teeth forward because you're going to push them off the bone support. I, by the way, can supply you with 7 articles from the refereed literature telling you that's not going to happen. But we still see people taking out teeth, ignoring those articles. So here it is. I told retainers, there's his teeth. They used to be crowded. They're not. There's space here. And later on, we can go in here and tie them up, make his teeth straight. But that's not the point. The point is he is now wearing a CPAP machine for sleep apnea. And the only way out of this for him is to have both jaws move forward surgically. I do not have anything short of surgery to offer this boy. Here he is at the time when most kids are going to get put in braces. And oh, by the way, most orthodontists would look at the spacing and close the spacing up, which of course would reduce his tongue space and airway. So that's his airway after I finish with him, which is the best I can do. So he needs surgery. And he's back, his face is back, but he doesn't look that different than many of the other kids in his class that he's going to graduate high school with. So I was at an American Academy of Craniofacial Pain meeting in Salt Lake City back in 2017, and a very well-known lecturer was talking about expanding, expanding, and expanding, and out of my mouth came these words, saying it to a friend of mine who was sitting next to me. I didn't even think about it. I said, you cannot expand your way out of an anterior-posterior problem. And these problems, sleep apnea and sleep disordered breathing, are an AP problem. You must be treating in the AP plane of space. Of course, now the literature supports that. It's not just Bill Hang saying that. Here we have none other than Christian Guilleminault, the late Christian Guilleminault, head of the sleep clinic at Stanford University until he passed away 6 years ago this summer, talking about how expansion may not really be able to make a difference. When your face is back that far, it's way too late. The point is, you're going to need to be treating much, much, much earlier. So let's look at one final case here. And I'm going to say to you, would you call 911 because you're smelling smoke if you saw this little boy here? Look at his boy with the red arrow over there. His mouth is hanging open about 20 millimeters. There he is when he's a teenager, along with his dad. There you can see his dad. This is off of Facebook, by the way. His dad is dying, right? He has no cancer. And so it's a very emotional picture here. What if you were to have gotten him treated and got him to a myofunctional therapist and became a nasal breather by this age? What if you got him when he was just that little kid there, or at least by the time he's a teenager? Instead of having him have upper bicuspids taken out to pull his upper teeth back that don't stick out because his chin doesn't exist. And as it was done, it arrests the growth of the entire lower face. You can see his chin is very, very far back. Now, when he comes to see me at age 49, he's been on blood pressure meds for 4 years. I sent him for a sleep study after I took his blood pressure and saw the stratospheric number, 163 over 120. I told him that he was going to die if he didn't do something. And he desaturated during that sleep study to 65%. They woke him up and sent him home. Why do you think they did that? Probably because they didn't want him to have a heart attack or stroke in their clinic and have a problem right there. It's bad publicity when someone dies or has a stroke or a heart attack in your sleep clinic. So basically, when you have blood pressure that's that high, that is the health equivalent of a California wildfire that took out the Palisades. Now, you can do double jaw surgery like this to bring his jaws forward, which we did. And his airway went on the left-hand side, by the way, is an airway that is probably bigger than many people who will be seeing this webinar. But for him, it was not good enough. The airway on the right-hand side is massive, 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 massive. I wish I had that airway. Mine is not that big, but he has no more sleep apnea. And more than anything, 10 days after his surgery, his blood pressure was down to 127 over 78, and it has remained down ever since. We're dealing with almost a decade since that time. His mother emailed me when I retired and wanted to meet me. She's from the Philippines. And I said, I'm sorry, I don't live in Los Angeles anymore. I live in North Carolina. I'd love to meet you, but I won't be there. But she thanks me for saving Bobby's life. And here's Bobby. He emailed me with his wife, and there he is in front of the Golden Gate Bridge in San Francisco. Thank my lucky stars for having met you. You changed my life, and for that, I'm forever grateful. I love that, to get an email like that. It's very gratifying. One of the most gratifying cases I've ever met. He drove 2 hours to see me before I retired. It meant a lot to me. And it's not that I'm special here. I'm teaching people. I'm passionate about teaching other people to do the exact same thing that I'm doing. First of all, not to ever retract anybody and cause them to be worse off than they were. So the point here is, when you see a baby laying in his mother's arms like this little baby is, with the mouth apart by 15 to 20 millimeters, or even a millimeter, this should be smoke to you, to tell you that there is a fire and you better call 911. This is not okay. One of my friends from my Rotary Club in California, we had this on Facebook several years ago. The grandmother with her mouth hanging wide open, the baby with the mouth hanging wide open. My point to you is, we must change this perception. We cannot allow this to go on anymore, because we know the health aspect is going on here. That child could be having sleep apnea and having brain cells being damaged every night. So again, I've shown you how all we're doing is rediscovering what people were doing more than 100 years ago. There really is nothing new. And this is my contact information. I'm happy to answer questions. You can see, if you want to contact for more information, orthodohealth.com, or you can email me at info@orthodohealth.com. thank you for your time. Again, I look forward to hearing from you if I can help you in any way.
That was wonderful. Dr. Herring, thank you.
You bet.
I'm back.
Okay. I'm going to click it all down. And
Yeah,
so
if you could stop your share. This way we
I'll
can
stop. Okay.
Perfect.
This is going to air on a Thursday night. What Thursday night will be?
I'm not sure yet, but I can let you know exactly which one.
Let me know because then I'll publicize it to my group. Okay.
We'll do. Yeah, I will. Are you able to take a couple of questions? Is that okay?
Absolutely. I'm here.
Okay. All right. I have a couple, and then there are a couple that were in the chat.
Okay.
The first one is when you're creating that overjet to be able to advance the jaws forward,
Yes.
is that always automatically corrected once the mandible advances, or does that not always occur?
It's a great question. And a lot of people will say if you were to move the teeth forward, the lower jaw will come forward. I wish that were the case. It doesn't. I have one case in my entire career of a girl that I moved the upper teeth forward on, and the mandible came forward on its own. We actually ended up putting in extra bicuspids. So she has 6 bicuspid teeth, 3 on each side, an implant on each side. She's now a dentist. Her dad was a dentist, and she's a dentist. That's 1 out of more than 50 years. The point here is you move the upper teeth forward and you create an overjet. Now you must move the lower jaw forward. And the only way it comes forward and going to stay forward is if the patient will learn to keep their lips together, their tongue to the palate, their teeth together, and adopt that posture, that rest oral posture, more than 20 hours a day over a period of many months, 6 to 8 months, perhaps even a year, wearing an appliance which negates the headgear effect. That's important. The appliance I use has some flanges that go to the floor of the mouth, and if the mandible wants to fall back, which the muscles want to pull it back, that signals the patient, oh, that doesn't feel good. I have to keep my jaw forward. So they learn to keep their jaw in that position. We're training them to have proper rest oral posture. We call it a postural appliance. It is not a functional appliance. It is not a twin block. It is not a bionator. It is not a Frankel appliance. It is not a Herbst appliance. It is not a Forceps. It is not a Trim Force bite corrector. It is not a Jasper jumper, all of which have headgear effects. And it's very challenging to wear. And to be honest with you, very few kids today have the intestinal fortitude to do it. But it can be done. And that's why I present it and I teach it. So and many of the people who take my course will do this for their kids because they see the benefits. But it's very challenging technically to do it for the doctor and for the kid to do it because they got to learn to keep their jaw still as a stone. They hold their jaw there and they have to learn to talk with their jaw completely still. But it can work, and that's where you get those kind of airway improvements. I wish there were a quicker way.
Okay. So what you're describing, that appliance is on the lower jaw? Or
it fits on the upper, but the mandible has to posture forward into it. And so there's a flange down that goes down into the floor of the mouth, and you activate it and put some soft plastic down there, which then becomes hard after it cures, and it keeps the jaw forward. So if the mandible wants to fall back, you have these things. Here's the floor of the mouth. Here are the front teeth right here. These things hanging down. It comes back. This touches the soft tissue on the inside of the floor of the mouth, and it doesn't feel good. So the child has to avoid that or it's going to hurt them. But they soon learn to do that, learn to talk with their jaw completely still, just like a ventriloquist would. And if they hold their jaw in that position for more than 20 hours a day, then ultimately that jaw is going to end up coming in that position. The condyles and the glenoid fossa will remodel, and that's all been described in the literature how that can occur. But again, very few kids have the intestinal fortitude to do it anymore. So it's very challenging.
Thank you. We didn't discuss this. I know you had mentioned extraction of bicuspids or premolars. What are your thoughts? And this was a question that was posed to me by one of my patients about extraction of third molars. A lot of the research isn't showing an impact on airway, but as an orthodontist, I'd like to know what you think.
Okay. I'm vehemently opposed to extraction of bicuspids. I'm vehemently opposed to closing missing lateral incisor spaces or even missing bicuspid spaces. All of those are retractive in nature. And anything that is going to bring the front teeth back and retract at all, you don't know how much retraction is going to be okay before someone has a problem. And what I've learned is it can be a fraction of a millimeter will cause someone to start to snore. That's from my own experience. Now, people ask, because I made my reputation for the last more than 40 years of my practice, that Bill Hang doesn't extract teeth. You know, the soccer mom on the edge of the soccer field talking to another mother, oh, my child's going to have 4 teeth taken out. Oh, no, don't do that. Go see Bill Hang. That was the reputation I had, and I wanted to have it because I went from extracting teeth more than half of the time to never extracting teeth. Now, the big subject came up about third molars. Okay, fine. Well, why are third molars impacted anyway? And people just don't understand this. They are part of the train wreck of the entire face coming back in Western society. You can see Daniel Lieberman's book on the evolution of the human head. He's a professor of anthropology at Harvard. He talks about how a Western diet, with what we eat and how we eat it, our faces don't grow forward the way they used to. Well, hello, the entire dentition falls back. The upper teeth fall back. The lower teeth fall back. And so 32 teeth don't fit into our faces anymore. And the third molars don't have room because all the upper and lower front teeth have been pushed back. Now, I always like to cite the Ethiopian and Kenyan runners who win the Boston Marathon and beat me by usually an hour and a half to 2 hours, by the way. I just come in an hour and a half to 2 hours later than they do. More like 2 hours later than they do, honestly. They have huge, broad smiles, and they will have third molars in place with space around them. Their faces are forward. They haven't had the luxury of eating our Western diet, which doesn't even require teeth. You don't even have to have teeth to eat what we eat. You can go buy the yogurt and squirt it out of a plastic thing, and you don't even have to use your jaws. I mean, it's kind of crazy. So the third molar thing is a non-issue. They we talk about having them taken out. That doesn't in and of itself affect the airway, whether those are taken out. The fact is the airway is already affected. If they're impacted because both of the jaws are back, and so that person already has a compromised airway. If their face was forward, as it should have been according to their genetic plan, they would have had room for 32 teeth. But how many people in our society today have room for 32 teeth? Very few.
I like how you put that. Thank you. That's a good framework to think of it. And so, you know, it's kind of, that's the tail end of the problem. That's
exactly.
kind of the consequence of a growth.
Yeah. Exactly.
This one may be a big question, but it is one that comes up. How do we approach, I'm guessing this is from a dentist, how do we approach orthodontists to begin treating in the early dentition without, the question is without insulting them?
There's not a breath deep enough for me to take to answer that question, unfortunately. I'm a traditionally trained orthodontist, and I was taught to do exactly what they were taught to do. And only by the grace of God that I start to question all of that. And I've gone through quite a change to get where I am. And I try in the nicest way I can to get across to people what my concerns are. And because I've been reopening extraction spaces, I started doing that in 1989, and I've done it for hundreds of people. People from more than 30 states and several foreign countries come to me in California for me to do that. I know the problems. I know that many of them are suicidal. You have no idea how bad it is, and the pain patterns they have, and the hundreds of thousands of dollars they've spent trying to find solutions. So I know the problems that we're dealing with here. And yet when I talk about that, I get shut out because nobody wants to change. I don't know a very nice way to say it. I can say it. Why don't you rethink this a little bit? And I often say, think about what you learned in your orthodontic training that's really evidence-based. What do you know that's evidence-based? There's very little. There's no science behind what we do. The angle classification is not validated. We routinely say we have to have teeth taken out for more stability, and yet we also say wear your retainers till full-time for a year, nighttime till the day you die, to keep your teeth straight. I mean, stability, there's not one study out there that's saying you're taking out teeth is more stable. The fact is, in dentistry, people say, I have an evidence-based practice. Excuse me, are you practicing? You're treating patients. No one has an evidence-based practice. I have an article in one of my lectures that talks about, is from an academic at one of the teaching dental schools, talks about approximately 8% of what we do in dentistry is evidence-based. 8. And yet, go online and see dentist websites, and they'll tell you they're evidence-based. That's a joke. It's a joke. Nobody's evidence-based. So it's a very, very daunting task to try to get through to people. The people that listen to me are the pediatric dentists. I love to have them in my course because they see the problems early on. And I'm going to tell you something that the world will change. I know it's going to change. I am convinced it will change. And the people that are going to change it are the mama bears, the mothers, because they understand, and they've read James Nestor's book, and many of them have had retractive orthodontics, and many of them are not happy. Many of them will move mountains and get on airplanes to fly for treatment and see me and other people to get treatment that's going to help their child become nasal breathers. They understand it. They understand all the health ramifications here. It's a big deal. And I'm happy to talk to any orthodontist. I'll be as nice as possible. But at the end of the day, they have to realize that they need to change what they're doing and stop retraction. I've written an article about this along with Michael Gelb, whose father was the TMJ guru in the 1980s, Harold Gelb. Michael and I are very good friends. And he coined the term airway-centric dentistry, which is a terribly important term. We have arguments about centric relation here in dentistry. And here's Michael Gelb talking about, yeah, that's nice. That was my dad's whole thing. But what's more important is the airway. The point is, do nothing ever, ever to compromise the airway. We need a completely new profession. And for those who are willing and want to be involved, that's what I'm here for. That's a very long answer, and I don't have the answer. If I had the answer, I would have long ago implemented it, because I lay awake at night saying, how can I easily and comfortably get somebody motivated to literally change everything they were taught? And I'm not joking. That's how big a change it is. That's what needs to happen. Retraction in all of its form need to happen. Most of what is done orthodontically retracts in one way or the other. Whether you take out teeth, wear headgear, wear class 2 elastics, if you take someone who's got space in between their upper front teeth and close it up, you're retracting. Unless you use temporary anchorage devices to bring everything forward, which nobody would do. But it's that big of a deal.
Yeah, I agree. It's a paradigm that needs to shift, and we're making headway, but it's going to take time.
We're making headway, and interestingly, I'm happy to talk to anybody. I really am. And anybody who's going to open the door for me to have this conversation, I'll gladly come through with a smile on my face.
Thank you. We're so appreciative of all the groundbreaking work that you've done and your generosity and being willing to teach others, especially those who are willing to listen and spread the word. So thank you very, very much, Dr. Hang. I will let you know when this will air live.
Okay.
To our members, keep an eye out for weekend newsletters with important announcements and upcoming guest speakers. And we look forward to seeing you at our next webinar. Thank you again for your time this Friday, Dr. Hang.
Okay. Thanks so much. We appreciate talking to you. Bye now.
My pleasure. Take care. Bye-bye.